Okay, so I'll go ahead. So, well, absolutely delighted to welcome David Grabowski, professor of health policy at Harvard University, a leading expert on long-term care and aging. And he will be speaking today to the question on COVID-19 and nursing homes in the US. Looking forward to the talk. David, the floor is yours.
Great, thanks, Joan, and hello everyone. So I'm just going to go ahead and share my screen here. Hopefully you can see that, right?
Yeah.
So thanks. I was just saying to Joan, I would love to be in London in normal times with everyone, but similar to what's going on in the UK, we're also struggling here in the US with COVID, not just in nursing homes, but obviously very worried about the fall and what that holds for us. But I've, like many of you, been very focused on how COVID has impacted our healthcare systems, and in particular, our long-term care and nursing home systems. And so I want to tell you a little bit about how the U.S. has fared. Spoiler alert, the answer is not great. We've really struggled with COVID in nursing homes here in the U.S., and talk about some of the measures we put in place, and then also conclude with some ideas for how we can actually reform the U.S. nursing home sector in terms of payment, regulation, organization, and delivery of services, such that we'll be better positioned for the next pandemic. So I'm happy to be interrupted with questions. I think Joan may through the chat interrupt me if things come up, but we'll definitely have plenty of time at the end for Q&A. So let me start with just some very broad statistics. And you'd think statistics would be very simple here on what's going on in the US, but one of the issues we really struggled with early on was that our federal government didn't collect information on the number of cases and fatalities in nursing homes. So these are taken from state data that the Kaiser Family Foundation has collected since the beginning of the pandemic in nursing homes and some other assisted living facilities in the US. So the US has about 16,000 nursing homes, and you can see here that we actually even have more than that in terms of cases, and because that encompasses some assisted living facilities. But we've had over 500,000 cases in long-term care facilities, in 20,000 facilities, leading to over 84,000 deaths. So not good. Those deaths account for about 40% of the overall fatalities here in the US. So just like the UK, a lot of our fatalities have occurred in the long-term care setting. So just to give you a sense of how deaths have evolved here, and once again, this is using that the state reported data to the Kaiser Family Foundation. You can see that by April, we had just over 10,000 fatalities. Things, April and into May were really bad months here in terms of nursing home fatalities. And I'll show you that in terms of what was happening here in New England, where I live, and in the Northeast more generally. Things have been pretty consistent since then in terms of fatalities. Things definitely haven't slowed down, but we haven't seen those rates like we did early on in the pandemic. And just to show you, just like Europe, as each country has sort of been on its own trajectory, the same has been true here in the US in terms of different states and different parts of the country. I'll start with a lot of the states here in the Northeast, like New Jersey and Massachusetts, which saw huge numbers of cases and deaths early on during the pandemic, but then things have been relatively flat, thankfully, since the early part of the summer. Then you have the states in the Sun Belt, like Florida and Texas, which didn't really have many cases early on, but then things really took off kind of midsummer. And then you have a state like California that's just sort of been consistent the whole time. We're not certain what, just a big state with surges at different times. And here's what that looks like. So these are actually our federal nursing home data. And what's, I think, interesting here is that the first point is that we don't have anything kind of back to March, unfortunately. So the data start that last week of May. But you can see that the end of that surge driven by states here in the Northeast where I live, things sort of fell. And then about 6 weeks after Memorial Day, we had that huge spike in the Sun Belt states. And then things have thankfully been declining, but once again, very worried about what we're looking like for the fall here. These are cases. What do deaths look like? Very similar trend. It was very high, in those early kind of the early surge here in New England, Northeast, and then sort of a second surge, once again, right around that surge in cases here in the Sun Belt states like Texas and Florida. What does the U.S. look like? So this is just long-term care facility deaths as a share of total deaths. Once again, the U.S. as a whole there in red is about 40%. You can see some states like New Hampshire and Rhode Island where it's up almost 80%, around 80%. And then you have states like Nevada and Wyoming that are quite low by comparison. I get a lot of questions like, why this variation? Some of this is just small states like New Hampshire and Rhode Island, Nevada, Wyoming, where a few cases in long-term care facilities can really skew their totals. That's part of the story. But I think the bigger part of this is also just data recording. So these are once again state data. For example, I want to point out, I don't know if you can see my cursor, but New York here on the far right. New York was one of our states. You probably read about it. Huge numbers of cases early on, yet they had real data issues in terms of attributing individuals who were hospitalized from the nursing home. A lot of those deaths weren't attributed back to the nursing home, but rather were attributed to the hospital. And so some of this variation is just inconsistent data. How does the U.S. look like relative to Europe and other countries in Asia and Canada? You can see we're not that far off. So these are great data that one of your colleagues, Adelina, puts together. She's done amazing work at ltccovid.org in terms of publishing information across countries. And you can see the U.S. I had us at 40. She has us at 41%, but very close to the kind of overall average across countries. And once again, Canada, Slovenia up around 80%, Jordan, South Korea, Singapore quite low. So it's interesting to think about. Just like the U.S. states have this big variation, so do a lot of these countries. And this was a great quote I wanted to pull out from Adelina, just from the Washington Post last week. Very few countries have really been successful, and a lot of their success has been about keeping COVID out of the community. If COVID gets in the community, it's actually going to get in the nursing homes. That's going to be a theme, as you can see here, internationally, but it's also a theme here in the U.S. that the biggest predictor of whether or not a facility has COVID in the building is whether COVID's in that surrounding community. And I love this quote, and so I'm just going to highlight it quickly. The idea that you could somehow protect the people living in care homes from whatever is going on outside just hasn't worked. And you can see the U.S. and Britain aren't too far apart here, between 4 and 5% of the deaths, individuals living in these facilities may have died from COVID. Huge rates and completely, obviously, unacceptable. What has been the excess mortality? We're still working on that issue at a kind of a nursing home wide basis. We need to get our claims data in place such that we can really do those kinds of analyses and come up with national estimates. But this was a piece I published with several colleagues, led by my colleague at Harvard, Michael Barnett. And we looked at 3 cities early on in the pandemic and just wanted to see what was the excess mortality in Cleveland, Detroit, and New York City. In terms, you can see the blue line here is just 2019, the kind of orangish yellow, I guess that's orange, line there is 2020. And you can see Cleveland, there was no statistical difference in terms of excess deaths in 2020 relative to 2019. These are EHR data for electronic health record data for about a third of the facilities in each of these markets. But Detroit, over 2 times higher fatality in March through May of 2020 versus 2019, 4 times higher in New York City, where we had that huge spike in fatalities. That peak week in New York City, 10 times the fatality in 2020 relative to 2019. So just a huge surge there. So given this huge excess mortality, most U.S. nursing homes have been in lockdown since March. I'll talk about some efforts to reopen the U.S. nursing home sector. What that's basically meant is no visitors. So family members have basically been shut out of these facilities. We've had very limited communal dining and activities. I think nursing homes were already pretty isolated and lonely places, and COVID has only made that more so. And I'll come back to this issue, but did want to show you a couple of slides on just how this pandemic has impacted residents beyond just the virus itself. So this was a survey done by Altarum, where they surveyed 365 residents in 36 states just to see kind of what happened to their kind of quality of life. And you can see whether it's visitors being allowed, outside activity, enjoying fresh air, communal activities, being able to eat in the dining room. Huge declines and their everyday kind of activities. And huge spike in loneliness. So there were already, as I said earlier, issues around loneliness and isolation, but you can see 3/4 of nursing home residents report feeling more lonely than usual during the pandemic, and over half of them say a lot more lonely. So why all these efforts? If we know kind of shutting down nursing homes, locking them down, keeping out visitors is such a has such a negative impact. We've spent decades trying to make nursing homes more engaged places. Why now, all these efforts to keep people out? It's really because of the asymptomatic spread of COVID. So this is a couple of papers we did in JAMDA and Clinical Infectious Disease, and led by my colleague Scott Goldberg. And it was sort of a happy or maybe an unhappy accident. I was working with a group of colleagues here in Massachusetts to set up COVID-only facilities around the state. So this was in late March, early April. We were trying to identify facilities that could become COVID only. And so we were going in and testing every resident at these facilities. So this was just a sort of a bizarre natural experiment. We went into a facility in Wilmington, Massachusetts on April 1st. As far as we knew and the facility knew, there was nobody that had any symptoms. And so we tested on April 1st, 97 residents using a PCR-based test. And you can see 52 tested positive on April 1st. We then, of those 45 who tested negative, we tested all of them, and another 31 tested positive among the staff. Tested on April 6th, 97 were tested, 36 tested positive. So this was with no symptoms. This study really woke me up to the idea that we're going to really need to be much more vigilant. I know this is old news by now about asymptomatic spread, but this just shows you how quickly things can evolve in a nursing home, where you can go from basically no cases in late March to almost every resident having COVID, and you can see here on the bottom. I know there's a lot going on with serology tests here. Sorry, but ultimately, 30 residents died from COVID, and so it's just really by April 15th. So things can obviously evolve very quickly from no known cases in late March to lots of cases and deaths by mid-April.
David, we have a couple of questions.
Oh, sure.
Stefan is asking about whether the high state mortality is driven by the fact that there is low population rates in those states. And then Sarah Machado is asking about whether there's any evidence of people moving out of nursing homes or out of long-term care, more precisely. Families taking the older people back to their homes.
Yeah, so I absolutely think some of the variation there, both on the high end and the low end, is some smaller population states where the denominators can get skewed more easily. That a few big outbreaks in a smaller state can really skew the numbers. So I think the answer is definitely yes there. I do think, however, among states with bigger samples, some of that variation is just data quality. Data quality there, Joan. I very much believe that that some of that variation just isn't real. It's about recording. And in terms, Sarah asked about the
people taking their families back home from.
Oh, that's absolutely happened. We don't have great data on that. I'm going to show you some occupancy numbers in a minute. Absolutely happening, and I think that's one of the research questions. We know occupancy is down because of fewer hospital discharges. It's down, unfortunately, due to fatalities. I absolutely think families have pulled individuals out of facilities, and it's been more anecdotal. But I'll show you some data in a moment on just overall numbers. So it's not just that COVID has impacted residents, it's also impacted the staffs as well. So these data are from the federal CMS COVID repository, so they don't capture the early part of the pandemic, but we have almost 200,000 confirmed cases, over 130,000 suspected cases as of the end of last month in terms of just staff alone. 900 plus staff deaths, way too many, and I'll try to put that number in some context in a moment. One of the reasons the numbers of cases and deaths have been so high among staff is really the limited personal protective equipment and testing that we've made available, and then we've also not paid our direct caregivers very well. Many of them make close to minimum wage here in the U.S. They have very few benefits. They often don't have sick leave as well. So it was always hard to be a staff member, a caregiver at a nursing home. This has been a particularly challenging time. And I just wanted to put this, I said I'd put the number of deaths in some context. So this is just a piece that came out actually January of this year, and kind of talking about the most dangerous, one of these features they do annually, the most dangerous jobs in America. And you can see logging workers and commercial fishermen were the two most dangerous jobs back in January, with logging workers just under 100 deaths per 100,000 workers. Just to give you a benchmark, we did a Washington Post op-ed where we did a calculation led by Brian McGarry with my colleague Lori Porter, and we argue now that based on the number of fatalities, it was 760 at that time, now it's over 900, that if that death rate continued over the course of the year, that would equate to more than 200 fatalities per 100,000 workers, more than doubling the rate of logging workers. So if you had told me at the start of the year being a direct caregiver in a nursing home would be the most dangerous job in America, I would have found that almost impossible to believe, but that's where we're at right now in the US. This also isn't surprising, because one of the main pathway into a facility is obviously through the staff, and I'll show you some data to support that in just a moment. But I was really taken by just how closely staff cases seem to trend with resident cases, and once again that early spike that we miss a lot of with the federal data, driven by the Northeast, and then that later spike in July, driven by the Sun Belt states. But it really does look like staff cases are maybe even just leading resident cases by about a week. It's shifting. Oh, hold on, I want to I also wanted to make the point that this pandemic has been really tough on the nursing home sector financially, and this really gets to Sarah's earlier question about both admissions, but also individuals being pulled out of the facilities in terms of the mean number of residents. Going back to the piece we published in JAMA, looking at Cleveland, Detroit, and New York City, you can see how admissions in 2020 are way below the 2019 rates, and also just occupancy, the mean number of nursing home residents in these facilities is also down. Even in Cleveland, a city where we didn't see, at least early on, a big increase in the number of fatalities. And that's data for 3 markets. These are early data, national data from Avalier Health. They're just looking at, once again, what was the percentage change in inpatient discharges. So that means individuals leaving the hospital. And this may be different than most European countries, but we both do long stay services in our nursing homes. We also do what's called post-acute or post-hospital care. And so a big source of revenue and admissions for our nursing homes is individuals coming from the hospital. And you can see, not surprisingly, we saw this huge decline March, April, May, and forward in terms of hospital discharges overall. So just fewer individuals in the hospital having elective procedures, a lot of individuals delaying care. But I just want you to look at that darker blue. There's been a big change in the volume of discharges to skilled nursing facilities, and that's persisted all the way out to July. Home health has rebounded, which is not surprising. Individuals feel a lot safer about being at home, but discharges to nursing homes, to skilled nursing facilities, has really been down, and it seems like it's going to stay down for a while.
David, we have a couple of questions.
Yeah, sure, absolutely.
One by Itamar Mejido, who's basically asking about staff working in multiple nursing homes, potentially being part of the problem, and whether there is good data about it. And then Michael Grignon, actually from McMaster, actually supports the same idea, saying that the same seems to be happening in Canada. And then we have a question as well from Oscar Brito from the Netherlands, basically asking about whether this will impact the safety culture in nursing homes.
Yeah, so starting with the issue around staff working multiple facilities, we absolutely have that, and there's been some really nice papers. I'm actually part of one team looking at this. What's been kind of fun is that, and there's not much fun about COVID, but doing the research on this has been really interesting. You can use cell phone data to actually see staff moving across different facilities, working at different facilities. And I'm part of one research group, and there's another as well from Yale and UCLA. And in both instances, we're finding that this movement across facilities of staff is definitely leading to the cross-facility spread. So there's no doubt that individuals having to work multiple jobs, once again, these are not well-paid positions. It's hard to have a full-time position at a single facility. And so by forcing individuals to work at several facilities, we actually absolutely contribute to the spread of the virus. And it fits really well into this crisis on top of a crisis. We had a lot of problems already in our U.S. nursing home system, and COVID was just layered on top of that, and a lot of those systemic problems really have helped obviously drive the spread of the virus. Towards the question of whether this has helped the safety culture in U.S. nursing homes, I think we had real problems prior to the pandemic around safety. We've had a lot of reports there. I do think the pendulum has really swung during the pandemic towards safety of not allowing individuals to have visitors, and really trying to almost overcorrect for the problem. And I have argued, and I'll argue some in a few moments, that I actually think that pendulum has swung too far, and that other countries have done a better job. The Netherlands being an example of that, where I think they've done a better job of balancing kind of quality of life against safety. So I do hope, if the question was going forward, will this change our safety culture? I absolutely hope so. But I think in the short term, I actually think we've swung, like a lot of things, we've gone too far in the direction of safety, and I think ignored resident dignity and quality of life. And I actually think that's done more harm than good. And I'll touch on that. I did want to just mention, for those of you less familiar about the U.S. nursing home system, that we've been talking about this crisis, and this is a great quote by my colleague Barbara Bowers, who said, this is really a crisis on top of a crisis. That it wasn't as if COVID has largely impacted a sector that was strong at baseline. In the U.S., we largely pay for nursing home services via Medicaid. Medicaid is not a very generous payer of services. We've had decades of poor quality, low staffing, low pay, disparities by race and ethnicity. We've had relatively few clinicians in our buildings. Our regulatory model, I will be kind and term it ineffective. It's been challenging for consumers and regulators to know what's a good quality facility. And then we have a lot of issues in terms of fragmentation in ownership across private equity groups and operators. And so I think all of this has made it challenging to kind of address COVID when you have a lot of inconsistencies and weaknesses in the system itself. And I wrote a piece back in April, and I still feel like this is true today. We get what we pay for in the U.S. in terms of nursing home services. We underinvest in these services via Medicaid. And I wrote with my colleague, Michael Barnett, again, COVID-19 has revealed the fragility of nursing homes' business model and our underinvestment in high quality long-term care. So I do hope, and I'll talk about this at the end, the U.S. really wants to put ourselves in a better position to stem the next pandemic. We really need to put more dollars and resources into this sector, and then hold the providers that are doing this care accountable. A big issue. Oh, go ahead, Joan. Yeah. Sorry.
So we have two more questions. Sorry for the interruption. So one
like Noah's Ark. They always come in twos here. This is great.
There's lots of interest here. One question from Ulrika Wimbledon, who's basically asking about risk strategies to protect staff, whether there is any evidence on potential risk strategies, whether testing, isolation, any evidence on that. It might well be that studies are not there. And then Brendan from Dublin is asking about closures. So any evidence of early closures of nursing homes due to COVID. And finally, we have another question from Stefan asking whether two countries with the highest nursing home mortality exhibit as well the greatest number of residents in nursing homes. So whether crowded nursing homes tend to have higher mortality rates.
Yeah, all of these are great questions. So to the first one, I think it's a little early to know whether PPE testing we haven't done this in the U.S., requiring staff to work at a single facility, there's a whole set of levers one could use to really address the high rate of cases and fatalities. I'll show you what some of the efforts have been in the US, but I think we have relatively little data on what works. However, I will say we haven't done a good job in terms of supporting staff. We haven't done a good job in terms of pay. We haven't done a good job in terms of providing them PPE, and we have done a pretty terrible job of testing here in the US. And so I would say on all of those fronts, we think all of those work, but it's a really good question. We don't have the data, but unfortunately, in the U.S., we're still at sort of, I think, square one in terms of actually implementing a lot of these on a broader level. And I'll show you some of that data. The second question was around closures. We've seen a lot of media reports. The U.S. government has provided relief funds, billions and billions of dollars to the nursing home sector. The Medicare Payment Advisory Commission, or MedPAC, suggests, at least in the short term, the sector is okay on a broad level, but obviously there's going to be some smaller providers that may close, and we're hearing a lot of reports of facilities potentially closing. So I do think there is that risk. And the third question was around I can't read my handwriting here.
Yes, so it was whether residents, so nursing homes that have more residents per room.
So that's a great question, and I think there's probably something to that. That we know community spread is so the question was around mortality country to country. Does some of that just reflect what share of the long-term care population is in facilities? I think that's absolutely probably true. We found it to be very reflective of where cases are in the community in terms of staff bringing it into the building. I will say that, I'm talking a lot about nursing homes today, and I'll mention this at the end, but I'll stress it now. A big push here in the U.S. going forward needs to be getting future cohorts of potential nursing home residents into the community. So that transition of growing home and community-based services will be a huge emphasis. And once again, I look at a country like the Netherlands, which has really invested in home and community-based services relative to the U.S. It's just I think beyond being a much better model and giving services to individuals where they want them. I think those approaches are much better and aren't dealing with a lot of the issues we're discussing today. So a lot of the focus here in the U.S. has been who's to blame, and I think Adelina's quote earlier really helps think about this on an international level. But why so many fatalities in nursing homes? Here in the U.S., we're always very quick to point at the nursing homes themselves and say, these are just some bad apples that have really driven this. And we have plenty of bad nursing homes here. So that's definitely a possibility. A lot of policymakers have also pointed at different states and said, there were state policies that were implemented or not implemented that really helped drive this. And then finally, is this a failure on a system level, on a national level, that simply the U.S. government didn't make a significant investment in protecting staff and residents? And we did a piece that we published in JAGS several months ago, where we looked at which facilities have COVID and which don't. We used data from 30 states. This was early on in the pandemic, before the federal data was available. And this won't surprise anyone, but there were certain features that were associated with facilities having a COVID case. Larger facilities, more staff in and out of the building, were more likely to have cases. Urban facilities, just once again, more activity in terms of COVID. And the share of Black residents was predictive of having a case. And here in the U.S., it's been the case that COVID has hit minority communities particularly hard. It's, nursing home services are local here in the U.S. The staff live in those neighborhoods. And so we think this is also just reflecting individuals bringing COVID from the community into the facility. So this piece got a lot of attention because it helped sort of was featured in the Wall Street Journal, but it helped kind of suss out whether this is a bad apples problem or whether this is about something bigger. And in terms of this being a bad apples problem, we looked at whether facilities with a higher 5-star rating on our federal Nursing Home Compare website. We looked at having a prior infection control violation, whether you were for-profit chain, a higher share of Medicaid recipients. All of those were unrelated to having a COVID case. It really was about where you were, not who you were in terms of a nursing home. If COVID was in the surrounding community, it was likely to be in the nursing home, and staff were the primary group bringing that in. You can see that once again, going back to our JAMA piece. This is just Cleveland, Detroit, and New York once again. You can see the top panel is just total weekly deaths in those metro areas. So this is all COVID deaths in the area. And then the bottom trend, once again, I showed you earlier, is just the weekly in facility. So nursing home deaths there over that same period. And you can see how they parallel one another. Cleveland, very slight increase. Detroit, a modest one. In New York, that huge increase. Nursing homes reflect the surrounding areas, unfortunately. And this led us, myself, Tamara Konecka, and Vince Moore to do a piece in the Washington Post, once again, where we argued that all facilities need our help. This isn't a bad apples problem. This is a system level problem. And we wrote, the expectation that good nursing homes can stop transmission while poorly rated nursing homes cannot is unwarranted. Many top rated nursing homes have been overwhelmed, while a lot of poorly rated ones are free of COVID, largely because their staff members live in areas with low rates of infection. It's about where the staff live. It's about where the nursing home is located. That's not to say we can't do anything, and I'll show you some data in a moment, but simply having a case is not reflective of a bad outcome. It's really about the surrounding rates in the community. I was part of a commission here in the U.S. That was put together by the Centers for Medicare and Medicaid Services. We were tasked with providing a series of recommendations to the federal government about how to respond at a system level. The point of this wasn't to actually figure out why we got into the problem we did. It wasn't to provide long-term solutions. It was really about addressing, it was a roadmap out of the sort of nursing home pandemic for policymakers at the federal level. And in green there, we made a series of recommendations in 10 areas. So we had 10 themes. 27 recommendations flowed out of those themes, over 100 action items. I will say the federal government has not, at a high level, taken a lot of our recommendations since we offered them a couple of months ago. But I did want to talk about a few of these issues today and just kind of how the U.S. is doing here in terms of responding to these to these areas that we really push the federal government to move on. So the first area, and this was these strategies came up earlier in one of the questions, but if this is a system level problem, then all facilities need testing. And early on in the pandemic, some facilities, some states were able to put together testing. But by and large, it was pretty haphazard, and I would say most nursing homes lacked kind of really comprehensive rapid testing. Some states, as I said, had tried universal testing. Some states and facilities had strike teams. Once a case had been detected, they brought in a strike team to do testing. More recently, the federal government has begun providing rapid testing to facilities. And this was a piece, once again, I did with Michael Barnett, but this is like, it took the federal government to July to really step up and do rapid testing. You can see the date on this piece we did in the LA Times. This was back in May. So the federal government was quite slow to address this issue here in the US. And as I'll show you in a moment, we still unfortunately have a long way to go. So Federal testing was announced in mid-July. The goal was rapid point-of-care antigen-based testing for all the staff and also residents and visitors at every U.S. nursing home. So the idea they could do 20 tests per hour, 4 to 5 million per month nationally. They targeted the 2,000 nursing homes most at risk in the U.S. So these were hotspot areas where COVID was particularly, outbreaks were particularly high at that time. We know there's accuracy issues with the antigen-based testing. This was a huge development, but at the time there were a lot of questions about this issue around accuracy, how well facilities were being trained in the use of this testing, and also who would pay for the supplies. The federal government provided the initial testing kits and supplies, but the idea that the facilities would have to pay for them downstream. So this is a piece we have that's currently under peer review, so I'd ask you not to post this or anything on social media. But in terms of how well we're doing with rapid testing, so the first point I'll make is I'm not an expert on testing, to say the least, but everything I've read suggests rapid should mean less than 24 hours. That basically, if you're waiting multiple days, that's a problem. So you can see across the top, panel A and panel C. These are taken from our federal COVID data. Very few facilities, whether you look kind of early on in late August or late September in the lighter shade of blue, very few residents, very few staff are getting testing back in less than a day. Most are 1 to 2 days. Unfortunately, a lot are 3 to 7 days. And a test that comes back in 3 to 7 days just isn't that helpful, as we know. Even 1 to 2 days is somewhat questionable. What about in those hotspot counties that were rolled out early? A little better than the national estimates, but not that much better. Unfortunately, we have a long way to go, even with the implementation. The early period of just hitting the hotspot counties, but now every nursing home in the country has access to this rapid testing, and you can see we're still not doing very well. The second sort of lever strategy I wanted to discuss was PPE, infection control, cohorting. PPE is really the best weapon we have in terms of containing COVID in the nursing home environment. Testing to me is very complicated, and there are lots of issues, and the U.S. is still, to say the least, struggling with testing. PPE, you would think, would be much more straightforward. Yes, there can be issues with correctly doffing and donning PPE, and there's certainly training needed there as well. But this is just simply a matter of supplies. And you can see here in the U.S. and these numbers, this was a piece that my colleague Brian McGarry led in Health Affairs. We published just showing data over the summer. And it's basically the case that in the U.S., and it's been pretty consistent over the summer, 1 in 5 facilities lacked adequate PPE. If you go down to the lower half here, 1 in 5 facilities also lacked adequate staffing. And so huge issues around just supporting our workforce. As I've already noted, we still aren't giving them rapid testing. We're still not providing them with personal protective equipment. And not surprisingly, a lot of facilities around the country are understaffed as well. And that leads very nicely into another strategy, which is obviously supporting the workforce directly through hazard or hero pay, non-punitive sick leave, if you can believe it. Many staff in this country risk losing their job if they call in sick, and so we really have undervalued the workforce in the U.S. Health insurance and other benefits are often lacking. Less than half of certified nurse aides in the U.S. have health insurance through their employer. And then are there ways to set up a living wage going forward? And I really like this paper because it really shows the importance of staff towards containing an outbreak within a facility. So this is work by Rebecca Gorgas and Tamara Konecka at the University of Chicago, and they show kind of on the left here, what is, they split staffing on the bottom here into quintiles, and so quintile 5 is the highest staffed quintile. You can see that in terms of having any case, not much of an effect. In fact, it may be the case that better staffed facilities have slightly more cases, but conditional on having a case, you're much better off having more staff. And this huge decline in outbreaks at these facilities that are better staffed. And so I get this question a lot. I said to you earlier that this is a system level problem, that all facilities can have cases, but the actual spread, the number of cases conditional on having COVID in the building, you really want more staff. It's kind of counterintuitive. More staff in and out can lead to having yes, no, any cases, but the size of the outbreak is really conditional on how many staff you have, and more staff is obviously better at containing a huge outbreak. This issue of low staffing, I won't belabor this. This is a piece we did pre-pandemic in 2019, where we're able to show that whether it's RNs, LPNs, or nurse aides, what percentage of the time were these facilities at the level recommended by the U.S. federal government? We have day-to-day, we have payroll data that shows us staffing on a day-to-day basis. You can see most facilities are out of compliance most of the time in terms of what's expected. This is just level of staffing. If you looked at turnover, same thing, lots and lots of turnover of staff. So we really historically haven't supported our staff very well. This is a piece I did with Richard Frank, Bianca Frogner, and John Gruber. We published in The Hill, and we did another one of these back of the envelope calculations in this piece, and we said, what if we paid our certified nurse aides, our direct caregivers, $10,000 more per year here in the U.S.? That's basically $5 an hour. This would lead to $20 billion more in spending per year. That's less than 1% of what the U.S. has spent in 6 weeks to fight COVID. So I know 20 billion is a big number, but it's really, in some regards, a drop in the bucket. So there's ways to really support this workforce going forward. I already mentioned this issue, but I get 5 minutes. Yeah, sure.
Just saying that 5 minutes. You have about 5 minutes, if that's all right.
Perfect, John. So in investing in, I often get people saying to me, why are you talking about putting more money in nursing homes when nobody wants to be in a nursing home? Why aren't we investing in home and community-based services and assisted living? My response, we can do both. We should be doing both here in the U.S. We need to support HCBS and assisted living as well. I noted earlier that we both care for long stay residents in our nursing homes in the U.S., but we also, they're the post-hospital, post-acute aspect of them. We need to continue to work here during the pandemic. I mentioned the efforts here in Massachusetts and elsewhere to create specialized COVID-only settings. I've been involved in some of those efforts, and once again, investing in home health care as well, such that when individuals are leaving the hospital, there's a safe place to do that, such that our hospitals don't get overwhelmed. And an additional point is obviously transparency and engagement for families. We did a piece of all of the op-eds that I've written during the pandemic. This is the one that folks had the strongest reaction to, because it's really about families getting back into nursing homes. And we argued that these continued bans, keeping what we called essential care partners, family members out, is leading to more harm than good. That I mentioned this pendulum, we've swung towards the side of safety. I think we need to swing it back towards resident quality of life and resident dignity. There have been efforts to reopen U.S. nursing homes. This is data from over the summer. More recently, CMS issued new guidance about encouraging outdoor visitation and providing a series of steps to actually encourage indoor visitation as well. So some final thoughts, and then happy to open it up for questions and comments. Nursing homes obviously need support right now in terms of testing, PPE, better pay and benefits for the workforce. I would argue nursing homes need support, but they also, we can't take our eyes off of them. They need oversight, accountability. We need family members back in there as well. And my vision for nursing homes isn't that we continue as business as usual, but rather that we start to reimagine what a nursing home can be. And I've written a lot of pieces on what the nursing home sector might look like post-COVID. This was a piece I did in the Commonwealth Fund. I won't read all of these to you, but it's basically reimagining not just the nursing home sector, but also home and community-based care. And it's about putting dollars in the pockets of caregivers, encouraging more physicians on site, really modernizing our long-term care benefit in this country, which has been neglected and really under-resourced for a long, long time. So I will stop there, Joan, and say thanks, and happy to open it up for questions and comments. So
thank you so much for such an insightful presentation. We learned a lot today, and there's a couple of quick questions that I could identify in the chat that were quite specific, and then we'll open it up. I mean, actually, one was more a curiosity I had, which is whether nursing home deaths actually compare to the deaths of elderly people as well in the community. Because I mean, I guess that your point that nursing home deaths reflect the community. Basically, if one way to test that is to look at whether people living at home has with a carer with some kind of home help, whether the deaths of those individuals compare, or whether there is any evidence that whether those deaths compare to the deaths in nursing home. So that's one question. And then we have another question about alternative forms of housing for old age, where basically, one of the points that was made is that it could be that all these nursing home crises might steer perhaps individuals out of the traditional nursing home setting, and perhaps there might be like alternative forms of residential care for older individuals, whether they would be have safer than current nursing homes. So we could start with those.
Sure. So I think the first hypothesis that deaths in the nursing home probably track pretty closely to deaths in the community is true. What we know less about in the U.S. is just what sorts of services, what kinds of environments are individuals outside of nursing homes. So unfortunately, we haven't just underinvested in nursing home data with COVID. We've also underinvested in community level data. And so I think that's going to take some time to really unpack. Were older adults who died in the community, were they receiving home care? Were they going to some sort of adult daycare program? Were they in assisted living, which we know fatalities have happened, but we just haven't had as good data. So, Joan, I think this is a rich area for future study, to say the least. But I don't think we know. In terms of the second question around alternative housing, absolutely. I think there's going to be both a move towards smaller home models. So I think these big institutional nursing homes and then community congregate housing, I'm hearing a lot of reports of individuals wanting to move to sort of smaller environments. And so I do think there's going to be a push there. But I do think that there's a lot of individuals that demand sort of engagement, that want sort of a higher quality of life that a community can provide. So I do think we're going to see new models and different models in terms of community-based environments. I think there's always going to be a role for these kind of congregate living environments because of the social aspect and some of the care aspects that I do think both balancing safety issues, but also that that quality of life.
Brilliant. Two more questions. One, very practical, whether the CMS Commission report that you mentioned is published. And the second one, whether there's been a cultural change in nursing homes as a result of COVID-19. I mean, do you see a cultural change taking place? And then Adelina is asking, is basically mentioning that in England, deaths of women with dementia at home increased by 75% compared to the previous year. Deaths in hospital decreased by 40%, which suggests an additional deaths coming from community living people. So perhaps there is some evidence there that could help on that front. I mean, if anyone has questions, just raise your hand and I'll just allow you through. But in the meantime, I wondered whether you have a quick answer to some of these or quick response to some of these questions.
Yeah, so I just saw Nancy Kuzmel put a link to the nursing home report in the chat. That is most definitely public, so feel free to have at it. Thank you, Nancy, for linking to that. So that one's easy. In terms of culture change, this has been a slow movement here in the U.S. I think we've made tremendous progress in certain nursing homes, but it's safe to say at a kind of a sector-wide basis, we have a long way to go. So I was involved in an evaluation of the greenhouse model, which is one such culture change model. It's a small home model. Staff are valued and engaged and paid well. Residents have complete kind of direction and autonomy over their lives. They get up when they want, they eat when they want. And interestingly, that model, in talking to the leadership there, has fared really well, even in areas with, like here in the Boston area, where we had huge outbreaks at a lot of facilities. The Boston area greenhouse fared really well, and that's been true nationally. Some of that is that the greenhouses were located in areas where there wasn't a huge spread, but even in areas with spread, they have consistent assignment of staff, fewer individuals in and out of the buildings. It's a home, not a facility. And so I hope, obviously we've taken a huge step back with COVID in terms of locking down our nursing homes and closing them to family. But I do think this is an opportunity to, I think, reimagine smaller home models with more staff and better paid staff. All of that takes money, and so whether we have the political will and to do this post COVID, there'll be a lot of individuals with their hands out who will have a lot of issues we need to address here in the U.S. as you do in Europe. So I have no doubt this is going to be really challenging, but my hope is that we're actually going to address that. And it's interesting, Adelina. The dementia. There was a great study here in the U.S. that actually was able to do something similar and just calculate the number of fatalities among individuals living with dementia, and the numbers were huge, both in facilities and in the community. And so I think when we have an opportunity to really unpack where individuals were living, I think we're going to be really taken aback by the huge numbers, not just in nursing homes are front and center, and it's been easy to focus on them because of the data. But I'm convinced that this pandemic and the impact has been much broader, and we'll see a lot of those fatalities in the community.
We have another question by Florian Cruz, who's asking, do you think that ownership status matters in the severity of COVID-19 in the nursing home sector in the US? For instance, do private equity-owned nursing homes perform worse? This is Florian from the Netherlands. So
great. Yeah, so two levels here. When we did our work, we actually found that for-profit ownership was unrelated to whether or not a facility had COVID. Just as a little bit of background, if you just looked at ratings, if you looked at lots of different quality measures, nonprofits tend to be better than for-profits here in the US. That's not true for every facility, but just on average. So it was kind of interesting that we didn't see big differences there. There has been a study by one of my colleagues, Ashvin Gandhi, who's out at UCLA, and they looked at the spread in private equity owned homes versus others, and they found this kind of counterintuitive result that private equity groups tended to do better in terms of keeping COVID out. And I think that surprised them. It surprised a lot of people. I think their explanation, which is interesting, is that private equity groups may have had more access to PPE and testing relative to other facilities. So I absolutely think that result merits further work, but at least early studies suggest nothing worse in for-profit or private equity groups, maybe even some evidence that the private equity-owned facilities were actually even doing a little better.
Great. I don't see people. I see people shying out in terms of like raising their hands. I see a question from Calso Thompson. Cultural change in a resource-constrained system response to a threat, of course, may not be positive. He talks about defensiveness, myopia, and unintended consequences. I understand that what he's asking is whether there is a long-term view here. And and then I see another one. What about environmental variables within nursing homes as mitigator of transmission in the US? Well-ventilated and open plan, better than small scale and closed with air conditions. I mean, basically housing conditions. That's the second question about.
Yeah. So the first, he's absolutely right that culture change is a longer run. You're not going to in the short term. It is about cohorting. It's about ventilation. That these smaller home models of this kind of huge capital investment that they require. That's going to be a longer run effort. And I do think balancing kind of some of the quality of life features with kind of the airflow safety, all of that, I think we will absolutely need to rethink in the U.S. But in the short term, it's been much more about how do we keep residents safe. So I actually think, as I said to an earlier question, I think in terms of culture change, we've actually gone in the wrong direction in the U.S. It's been shutting down nursing homes, providing kind of less autonomy and ability to direct their own care on the part of the residents. And so I hope the pendulum will actually come back. Oh, I think you're on mute, Joan.
Okay, great. So yes, sorry, I was muted. So and then a final question, basically just thought about where to invest first in the future, and what would be your priority areas? I mean, you've touched upon it already, but maybe you want to stress something as a response.
Yeah, I always go back, like 60 to 70% of costs in a nursing home are labor related. And once again, to use the phrase I used earlier, we get what we pay for. And here in the US, you could tell me about the UK, but at least in the US, our caregivers make close to minimum wage. They're predominantly women, many immigrants, individuals of color. As I said earlier, they don't have benefits. I just think this is a forgotten and undervalued workforce. And if we really want to change nursing homes around, this is a way to do it. It takes money, of course, but I think that kind of investment, even the investment that I wrote up in that piece with Bianca, John, and Richard, where just putting $5 more per hour into the pockets of these caregivers could go a long way towards encouraging more individuals to work in nursing homes, retention, and quality of life and quality of care for the residents. The other factors about kind of longer term, around basically reconceptualizing or reimagining a nursing home and community based. We could do all of that, but I think the first step in a long term, if the question was shorter term, I would say personal protective equipment. I'm still angry that we lack PPE, but I won't end on another rant. So I will. It's remarkable to me, though. I will say this: my wife and colleagues and others are teasing me. Are you still talking about PPE? We're on month 7 of this pandemic, and I'm tweeting about it and getting asked by reporters about it, and I feel like I can only say it so many times, but it still hasn't happened. And so I don't know how many more times I and others have to say it until it actually happens. But it's pretty amazing that we haven't addressed this in the U.S.
Well, just reiterate how happy we are and how delighted we are with your presentation and your participation in the seminar. And as always, you're welcome to join us anytime in the future, and looking forward to see you face to face.
Absolutely. I hope I can make it to London at some point or after this post-pandemic. It'd be great to spend some time with everyone. It's good to see so many friends, and some of you are popping up now, but it's good, Sarah and Adelina and others. It's good to see everyone.